Greetings, everyone, and welcome to Emory University's School of Law's second lecture in the Conversations about Racism in the 21st Century series. I am Professor and Vice Dean Joanna Shepard, one of the organizers of this event, along with my colleague, Professor Dorothy Brown. Before I introduce our distinguished speaker today, I'd like to remind everyone of the purpose of this series. Emory Law believes that we have a critical role to play in dismantling systemic racism seen in so many areas of our society, including education, banking, healthcare, housing, the criminal justice system, and the electoral system. This series is one way in which we are trying to educate ourselves, our students, and the broader community about the role of the law in perpetuating racial injustice. Last month, we were joined by Professor Fred Smith, who talked to us about qualified immunity. Today, I'm thrilled that we have close to 100 faculty, students, staff, and alumni joining us today for the lecture of Dr. Kimberly Jacob Arriola. Dr. Arriola is the Charles Howard Candler Professor of Behavioral, Social, and Health Education Sciences in the Rollins School of Public Health at Emory. After graduating from Spelman College in 1994, Dr. Arriola earned a master's degree in 1996 and then a PhD in 1998 from Northeastern University, both in social psychology. She went on to earn a Master's of Public Health in Epidemiology in 2001 from the Rollins School of Public Health here at Emory. For the past 20 years, her work is focused on social and behavioral factors that impact the health of African Americans. More specifically, she has examined and intervened on social factors that drive racial disparities and access to renal transplantation. She has also helped evaluate interventions that seek to reduce racial inequities in HIV and AIDS, cancer, and other chronic diseases. Aside from being a faculty member, she also serves as the Executive Associate Dean for Academic Affairs for the Rollins School of Public Health. Today, Professor Arriola will lecture on the racial disparities in healthcare. She will speak for about 30 minutes, and then I will facilitate a short question and answer period to follow. If you have any questions throughout her talk or after, please use the Q&A function on Zoom to submit your questions. Okay, Professor Arriola, the floor is yours.
Thank you so much, Joanne, for that kind introduction. I'm just going to start sharing my screen. Great. So hopefully people can see my screen okay. So it really truly is an honor to be invited to speak today. I will just start by acknowledging that I am both a friend and a fan of Carol Anderson, and it is humbling to be part of a lecture series that she's also participating in. And so I encourage people to consider attending her talk, which I think is the next and the last session in this series. So again, I'm going to be talking about racism, and health, and I also want to start by thanking Dorothy Brown for the invitation to speak. I am here out of the greatest admiration and respect for Dorothy. She has been a longtime friend of mine as well. So really, just happy to be here today. But you'll find that this topic of race, racism, and health is something that I am extremely passionate about, and so I very much enjoy opportunities to engage on this issue. I have no relevant financial relationships to disclose. But what I would like to do is start with a story. This is Benjamin Slater, a Philadelphia teacher who visited an amusement park on a recent Father's Day with his mentee, girlfriend, and several others. He has visited this park many times before, and one of his favorite rides is the Steel Force roller coaster, which the group made a beeline for shortly after arrival. When Slater exited the roller coaster, he was approached by a park security officer with an unexpected request. "Your pockets are bulging. I want to know what you have in them." Now, Slater initially thought that his group was playing a Father's Day prank on him, but he showed the officer the contents of his pocket: a cell phone, a wallet, and car keys, despite the fact that he had already been checked by security a short time before at the park's entrance. Not possessing weapons or anything that would be cause of concern, Slater assumed the interaction was over and proceeded to walk away. It was then that the security officer began to question him further. Slater recounts, "He said he had gotten phone calls and that I matched the description of someone who was going through purses and bags." Slater began to record the incident, and as he was escorted through the park, he began to use obscenities towards the officer. As a result, The Whitehall Township police officer cited him for causing a public inconvenience. In addition, Slater has been banned from returning to the park for 6 months, although he was eventually released from authorities. Now, take a moment and reflect on how Mr. Slater must have felt. From the excitement and exuberance of stepping off of your favorite roller coaster ride to the rage, embarrassment, and humiliation that arose from this incident that effectively ruined Father's Day for Mr. Slater. And the number of these incidents are too many to count. Just a few that you may have heard of in the news include Kelly Fife Marshall, for whom the police were called as she checked out of an Airbnb with friends. Lolade Siambola, who was caught sleeping while Black in a common area of her dorm in Yale. Christian Cooper, recently, the police were called for his bird watching behavior in Central Park. A Black family having a barbecue at Lake Merritt in Oakland. Dante Robinson and Rayshawn Nelson were arrested during a business meeting at Starbucks in Philadelphia. The list goes on and on. So you may ask yourself, what drove these incidents? What's interesting is that many of these incidents come back to this idea that African Americans are moving into traditionally forbidden spaces. The Airbnb, Yale, Starbucks, these were places that it may not have been assumed that African Americans belong. And so there's these underlying assumptions about where Black people do and do not belong. There is a racial superiority that seeks to exert control, as well as presumptions of guilt, these presumptions that African Americans are doing things that they're not supposed to be doing. And all of this is in a historical context of the use of policing to exert control over Black bodies. Now, what's interesting is that these particular incidents were captured on cell phone videos, so they garnered national attention. But what about the many times that there was no video footage? What about the times when the slight was less overt, perhaps offering poor service in a restaurant or telling a Black customer that her size is not available simply so that she will hurry and leave? I'm going to try to shed light on these issues today, particularly as they relate to health, by answering 4 interrelated questions. And I'll tell you, the reason I entered the field of public health was quite simply to understand how racism gets under the skin. This was the topic of my dissertation 22 years ago. And so I'm going to first start this presentation with a discussion of what we mean by racism. I'm going to talk about what is known about race and health before talking about what is known about racism and health. And then I'm going to end with a discussion of how we can combat racism at multiple levels of influence. Now, my research over the last 20 years or so has largely focused on racial disparities in access to renal transplants. I have spent a lot of time thinking and talking and writing about racism as a driver of these disparities in transplant. So as a result, I'm going to use some examples from my own work that harken back to the transplant literature in today's discussion. But given the audience, I'm going to try to kind of keep it broad and talk about health more generally to the extent that I can. So let's start with some definitions. There are many definitions of race. There's general consensus that this is a social construct, not a biological concept. This idea is firmly established in the research literature and stems from the fact that there is much greater genetic heterogeneity within racial groups than between racial groups. So when I use the term race, I'm referring to a socially constructed set of categories used primarily as a basis of social inequity and social oppression. It precisely captures the impacts of racism. Racism is an organized system, and that system is what is really important here, premised on the categorization and ranking of social groups into races. And there's these 3 key things I want to draw your attention to. It devalues, disempowers, and differentially allocates desirable societal opportunities and resources to racial groups regarded as inferior. Now, it's well understood that racism is entrenched in the US society and that race intersects with other identities to shape how racism is experienced. Health is not merely the absence of disease. It's a state of complete physical, mental, and social well-being, according to the World Health Organization. It is a human right that should be distributed according to need, and it may be undermined by discriminatory policies, practices, and processes regardless of intent. And that's the key piece, regardless of intent. So the American Public Health Association concludes that racism serves as a driving force of the social determinants of health, like education, housing, and employment. And it is a barrier to health equity. APHA further indicates that racism structures opportunities and assigns value based on how a person looks. It creates conditions that unfairly advantage some and unfairly disadvantage others. It hurts the health of our nation by preventing some people the opportunity to attain their highest level of health. So Kamara Jones is a longtime colleague of mine and scholar in public health, who is also former president of the American Public Health Association. And she has acknowledged that racism saps the strength, these are her words, it saps the strength of the whole society. We must recognize that we all have skin in the game to dismantle this system and put in its place a system in which all people can grow and develop to their full potential. APHA further argues that racism operates at various levels in society, and it may be intentional or unintentional. So some of you are aware of Kamara Jones' work on the 3 levels of racism. She very eloquently describes how historical context explains the long history of racism in driving health. She argues that race-associated differences in health outcomes that are seen today are a direct consequence of racism that has been in operation for over 400 years. So she talks about these 3 levels of racism. What is really clear is that structural racism or institutionalized racism is foundational to the other 2. So what I'm going to do today is I'm going to define each level, but because structural racism is so foundational to all other forms, I'm going to just very briefly touch on internalized racism and personally mediated racism, because I really want to spend the majority of this presentation focused on structural racism. So I'm going to go a little bit out of order in terms of influence, and start with the definition of internalized racism. So internalized racism, this type of racism is characterized by members of stigmatized races' acceptance of negative messages about their own abilities and intrinsic worth. It's characterized by their not believing in others who look like them, and in fact not believing in themselves. It causes African Americans, in the case of anti-Black racism, it causes African Americans to devalue themselves and the group more broadly. Personally mediated racism is comprised of prejudice and racial discrimination. And when I talk about prejudice, I'm talking about this evaluative judgment about others' abilities, motives, and intentions. And racial discrimination is the behavior, the differential behavior towards others of another race. And so this is what we think about when we think about racism. We're typically thinking about this individual racial discrimination. Features are that it may be intentional or unintentional. It maintains structural barriers and is condoned by societal norms. But again, both of these forms of racism are fed by structural racism. There's a large literature linking perceived discrimination to health outcomes, and I'm going to just touch on this briefly shortly. So this is the type of racism, institutionalized racism, structural racism, that I'm going to spend the majority of my time today discussing. Institutionalized racism permeates the structure of society and shapes the life chances of individuals in racialized ways across multiple domains: political, social, economic. Now, in contrast to the other forms of racism that were just described, this type of racism refers to these macro level systems, right? These broad social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequities among racial and ethnic groups. And so just social segregation is a common form of structural racism that's discussed in the research literature. And I have this picture of Pine Bluff, Arkansas on this slide because it has been deemed the most segregated metro area in the country. An estimated 54% of the Black population of Pine Bluff lives in predominantly Black neighborhoods, which is more than 3 times the 17% national figure. The mechanisms in which societies foster structural racism is through the systems of housing, education, employment, earnings, benefits, credit, media, healthcare, the criminal justice system that reinforce discriminatory beliefs, values, and the distribution of resources. So in sum, racism operates at multiple levels and through multiple mechanisms. It operates in our structures, policies, practices, norms, and values, all of which offer different elements of decision-making. So I've heard people ask, well, the policies and laws that explicitly support racism, like Jim Crow laws or legalized segregation, they've ended. So why do the remnants of these policies remain? I'm arguing that it's because racism remains rooted in our structures, our practices, our norms, and our values. So we have to be intentional about not only changing policies, but also dismantling the structures, reevaluating our practices, and questioning our values if we are to make any progress towards eliminating the health effects of racism. Now, because racism is so nimble, it has changed in the ways that it operates over time. I'm going to talk about three forms of racism that existed historically as a way to kind of lead up to what we see as contemporary racism today. And so let me start with dominative racism, which this involved a system of intensive, sadistic, and direct control to produce the super exploitation of slaves. Right? So this upheld the institution of chattel slavery, and it ended in 1865. Dominative/aversive racism refers to the Jim Crow system of segregation, and this is thought to have existed from about 1865 to 1965. Now, aversive racism is thought to have existed from about 1880 to about 1970. And it emerged in the North as northern industries and urban areas exploded in growth. This form of racism was associated with racially segregated cities, resulting in racially segmented and hierarchical labor markets. And so it was marked by the hierarchy of labor that concentrated Blacks in the lowest paying jobs, least desirable, unskilled, and industrial jobs, and excluded them from the higher paying skilled jobs. It aligns with this idea of Blackness being associated with being poor as a result of biological inferiority. It promotes images of the Black welfare queen who relies on government assistance to survive out of a lack of motivation to work. Now, this fourth and current form of racism is metaracism. And this is thought to have ascended in the early 1980s, and it's a revised, refined, subtle form of racism. And it replaces the biological determinism of previous forms of racism with cultural determinism. And in part, it's because the rise of the Black middle class, and that's why I have a picture of the Jeffersons here, the rise of the Black middle class debunked the idea of biological determinism, so old forms of racism no longer fit contemporary realities. And so this type of racism relies on euphemisms, innuendos, and code words. It legitimizes microaggressions, which people debate on, whether it's a micro or macro. We'll not have that debate today, but microaggressions generally refer to actions or statements that serve as indirect or subtle or sometimes unintentional discrimination against members of a marginalized group. Now, metaracism operates through structural, cultural, and political dimensions. And so when I talk about structural dimensions, I'm talking about how it contributes to and maintains concentrated poverty, particularly among communities of color in this country, and very strong and profound income inequities in this country. From a cultural standpoint, it relies on and supports desensitization to oppression. Now, it's clear that the videos that we've seen of Black individuals being murdered in recent times, these are not the first incidents. This is not the first time these things have happened. They've existed for quite some time, these actions. But the reality is that the video footage makes it difficult for us to maintain that desensitization to these experiences of oppression. It puts things in people's faces. And so it's going against this cultural dimension of meta-racism is what video footage really does. And then the political dimension really speaks to this issue of values that support individualism, self-reliance, kind of pull yourself up by your own bootstrap. If you can succeed, you will succeed. And that small government is the best route, even at personal cost. And I'll just say as an aside, I probably tonight I'm going to finish this book that I've really been enjoyed reading called Dying of Whiteness by Jonathan Metzl, in which he describes how the politics of racial resentment is killing white Americans in 3 states in America's heartland, Tennessee, Kansas, and Missouri. And in this book, he eloquently lays out this political dimension of meta-racism. That's exactly what it's about. And so I'm arguing that it is these structural, cultural, and political dimensions of meta-racism that impact the health of African Americans. But let's take a step back and answer the most basic of questions. What determines the health of a population? Now, the answer to this question lies in these 5 highly interconnected categories. I'll start at the bottom. We now know that the role of genes in biology is much smaller than once thought. As a country, we put substantial financial resources towards the delivery of medical care, yet this too is not the critical driver of the health of populations, not to offend any clinicians who happen to be on this call, because I'm equally critical of my own field, behavioral and social sciences. For quite some time, we placed great emphasis on changing human behavior without deeply appreciating how the social, cultural, and political environment shapes that behavior. So for example, in the early 90s, it became really clear that in the HIV epidemic, Black women had increasing prevalence of HIV/AIDS. And so there were interventions, health behavior interventions that did a range of things, including teaching women how to put condoms on their partners. And the way you could do it potentially is you practice on a banana. So you have a woman practicing putting a condom on a banana without acknowledging the larger socio-political context that shapes whether she can even impact the decisions around protection in that relationship. What are the power dynamics of that relationship that determine whether the woman has a say over the type of protection that will be used? That we miss that. And so our field is really kind of, in my opinion, kind of coming back and really starting to focus on, over the last, I would say 10, 20 years, starting to focus more on those macro social factors. It's been well documented that aspects of the physical environment influence our health, vis-a-vis the air we breathe and the food that we have access to. But again, it's this 5th category, social factors. It's these social determinants of health that encompasses economic and social conditions that influence the health of people and communities. These conditions are shaped by socioeconomic position, which is the amount of money, power, and resources that people have. It is in this box that structural racism resides. Now, one of the challenges of understanding how race and health are related is that as a society, we tend to be ahistorical. It's easier to focus on the contemporary understandings of racism than to look back into the past. After all, you can't change the past, right? Or I wasn't even alive when those bad things happened. But history matters, particularly when its remnants are still felt today. Bird and Clayton provided a nice historical overview of Black-white health disparities by arguing that they are rooted in 246 years of chattel slavery, including a slave health deficit that existed back then, 100 years of legal segregation and discrimination in a Negro medical ghetto, and this is moving into what I call the diminutive/aversive racism, to the contemporary social, political, and economic isolation, oppression, exploitation, and a dual and unequal health system, where many Black Americans continue to receive substandard health care. We know that African Americans are more likely to lack health insurance and less likely to access needed health care. For many, without the means to pay for health care, public hospitals and community clinics remain the safety net. They serve as a safety net. These authors conclude that virtually all of the data suggests that from our country's earliest beginnings, Black, poor, Native American, and immigrant populations suffered the worst health outcomes, status, and access to healthcare. So although racism has evolved over time from being diminutive to the meta-racism that we talk about today, we now experience, it's very clear that the pervasive health disparities that continue to exist are evidence that racism is still in operation. And as an aside, I have this picture of Meharry Medical College here because discrimination against African Americans to enter medical schools and teaching hospitals in Tennessee was so extreme that in 1876, Black physicians opened one of the nation's first African American medical schools, considered the first of its kind in the South to serve the Black community. So what do these health disparities look like? There's a large public health literature with well-documented health disparities based on race. And I'm gonna sum this up quickly in just a few slides. It doesn't take a lot to make this point. What the graph on the left is showing you is that non-Hispanic Blacks have a higher death rate than whites and Hispanics. This slide is showing, and keep in mind that there are very real gender effects when it comes to life expectancy. So this slide is demonstrating that white females have a higher life expectancy than Black females, and that white males have a higher life expectancy than Black males. Now, because we're living, because we're living through a global pandemic, I would be remiss if I don't say something about the clear evidence around racial disparities in COVID. This slide demonstrates that African Americans as compared to whites, and this data, I'll even admit, this data is a little bit old, but I really like this infographic that the CDC created. So, my sense is that the numbers, are going to shift a little bit, but these trends are not likely to change, not likely to have changed since August. That African Americans have 2.6 times the cases of COVID as whites, 4.7 times the hospitalization, and twice the death rate. Now, in my own field, in transplant, we have well-documented racial disparities in every step of the process of getting a transplant. So this is kind of the process for getting a transplant. And African American patients are less likely to be referred for transplant, to start the evaluation process, to complete the evaluation process, to be placed on the deceased donor waiting list, and to undergo any type of transplant. And indeed, live donor transplant offers numerous health benefits over deceased donor transplant. African Americans are less likely to undergo live donor transplant. And so the literature is just very clear that African Americans have reduced access to transplant as compared to whites. And unfortunately, transplant is the therapy of choice for many patients with end-stage renal disease. Studies have repeatedly documented racial and ethnic differences in access to invasive diagnostic and therapeutic interventions for heart disease and stroke. Now, this is of particular importance because heart disease and stroke are the first and third leading causes of death in this country. Cancer is the second leading cause of death, and findings vary by site, certainly, but generally, African Americans present at later stages of disease and face greater delays between diagnosis and treatment initiation compared to white Americans. Some studies have found that African Americans are less likely to undergo major therapeutic treatment like surgery, but findings are less consistent in this area. And so explanations for these disparities initially focused largely on biological inferiority, and that's the biological determinism that I talked about that was linked to the earlier forms of racism. And it's kind of shifted to behavioral negligence. So the differences in death rate and life expectancy that we see are because of the behaviors that African Americans engage in. They won't eat right, or they don't exercise. It's their fault. They're not engaging in the healthy behaviors that we know to be protective. But the literature is increasingly zeroing in on structural racism as a key driver for these clear and profound racial disparities in health outcomes. And so Bailey et al. Suggested these pathways in which racism impacts health. And I loosely categorize them as existing at the macro, meso, and micro level. So I'm going to present just a few studies that I've personally been involved with that kind of illustrate each of these three levels of influence. So at the macro level, there's this economic injustice and social deprivation as the pathways through which racism may impact health, and the environmental and occupational health inequities. And there's a lot of work that suggests that the historical policies, laws, and practices impact subsequent generations. And so this term intergenerational drag has been used to characterize that phenomenon. So in this 2012 study, I collaborated with Cheryl Gabriel-Mendola in the School of Medicine, and Michael Kramer and Hannah Cooper, and who are faculty here at Rollins, and a couple of other individuals. Emily Russell was a doctoral student of mine, to conduct a study of 22,000 women who had been diagnosed with breast cancer to understand the relationship between residential segregation and both breast cancer and all-cause mortality. And what you can see in this slide is based on metro and micropolitan statistical area measures of segregation, based on that measure of segregation, as segregation increased, there was an increase in breast cancer mortality for Black women, whereas for white women, it remained flat. Now, there's a lot of different ways of measuring residential segregation. And in fact, the literature suggests that some of the impacts on health vary based on the measure that's used. And you can see that exactly here. The right box shows the findings for all-cause mortality. And what you can see here is an interaction between race and segregation based on the percent of the census tract that's Black. So what you can see is that as the percent of Black residents in the census tract increases, all-cause mortality actually increases for white women, and there's a very negligible decrease for Black women. And so, there's some really interesting trends and interesting ways to look at these macro level factors and how they ultimately get under the skin, how they come to be embodied. This study, this next level, the meso level, refers to targeted marketing of commodities that can support or harm health. This includes the availability of fresh produce or the concentration of retail liquor stores, neighborhood safety, walkability, social and behavioral norms, inadequate degrading healthcare, state sanctioned violence, and political exclusion. In this paper, I co-authored with Reem Hamoda, and actually Reem Hamoda was part of Rachel Patzer's group right here in the School of Medicine, right here at Emory. But we explored relationships between perceived experiences of discrimination and evaluation. This is evaluation for transplant for 500 Black and white patients who had been diagnosed with end-stage renal disease. And they had been referred for evaluation at one of 3 transplant centers in Georgia. And what we found is that experienced discrimination in a healthcare setting, as well as perceived racism in healthcare settings, were associated with lower evaluation initiation. So back to this earlier slide I presented. So you have to be referred for transplant, and then you start the transplant process after that referral occurs. This study is saying that these issues of racial discrimination could serve as a barrier at these earliest stages of the process, even preventing patients from getting to the later stages of the process, which is very disheartening. And then at the micro level, this includes psychological trauma, maladaptive coping behaviors, stigma of inferiority, and complex and long-term biological pathways like biological wear and tear, epigenetic processes that show genetic variations that occur as a result of environmental changes, as well as emotional and physical stress. And so I'll just very briefly present this study where I collaborated with Dave Che and others. Dave was a former faculty member here at Emory, and we sought to examine associations between racial discrimination, mood disorders, and cardiovascular diseases among Black Americans. And what we found is that participants with a history of mood disorder who also reported high levels of racial discrimination had the greatest risk of cardiovascular disease. And then just lastly, this is a study that I'm currently involved with. It's a small study funded by the National Institutes of Health, where we're looking at chronic kidney disease patients. These are all African-American patients. They completed a range of different psychosocial measures on an iPad, including experiences of racial discrimination. They went home, came back a few days later for a clinical aspect of their study involvement, and include a blood draw to assess measures of systemic inflammation. And for this very small study, among patients who have chronic kidney disease, we found that perceived discrimination was associated with depression, and that depression tended to be associated with systemic inflammation, which suggests that depression may be a pathway through which perceived discrimination is associated with systemic inflammation. So to summarize, this literature, what do we know about the effects of racism on health? This literature provides ample evidence that racial discrimination, both perceived and anticipated, I didn't even get to talk about anticipated discrimination today, but it's associated with poor health across a range of different health outcomes. The evidence on structural racism is growing, and there's some work that suggests that congenital heart defect mortality and infant mortality may be associated with some measures of structural racism. But some of the challenges of this literature include the focus on the individual. There's been a large focus on interpersonal racial discrimination, or the personally mediated racism that I talked about earlier. And so because of this focus at the individual level, interventions are largely occurring at the individual level. This literature faces challenges with measurement, of course. Some of the greatest challenges are around measuring structural racism. There are some really interesting and provocative measures of structural racism that have been developed and are being developed, and this is an area that's really growing. People are measuring structural racism in a range of different ways. They include factors like voting, the voter registration, employment rates, income inequality. So there's a lot of measures you can use at the population level that are indicators of structural racism. And so there's, again, just a lot of great work that's happening in that area, but we still need more studies and interventions at that higher level, that structural level. Because we believe strongly that the macro level interventions will have the greatest impact. And so what can we, the final portion of my presentation is really going to answer this question: how can we combat racism racism in general across multiple levels of influence? And so I'm going to talk a little bit about what role we all can play in this process. And so, the literature on structural racism might lead readers to believe that the structures that need fixing must be addressed by policy and lawmakers, governments, right? But I want to reframe the narrative to one that empowers all of us to change these structures. We all have a role to play in combating structural racism. It's typically thought of as operating within and between societal institutions like, say, the healthcare system. But that definition misses the lower level structures that we might very well have influence on. I believe that there are multiple levels of structures in which racism operates and are amenable to intervention. So of course, at the societal level, we need healthcare policy and health insurance for all. We need to address disparities in access to quality education, employment disparities and income inequities. We need to examine neighborhood characteristics and how disparities in certain characteristics contribute to health disparities. Professional organizations have important work that they need to engage in around educating staff and patients, helping to develop a culturally competent workforce, and strengthening linkages between providers. And that's particularly relevant in my field, where you could have a community nephrologist that diagnoses a person with chronic kidney disease, and then there's little interaction between that nephrologist and dialysis facilities, or between dialysis facilities and transplant facilities. We need seamless interactions between these different sub-institutions, if you will, within healthcare in order to strengthen the linkages for patients who are likely to fall out at different levels along the pathway. Institutions of higher education, of course, provide the space to conduct the scholarship. I've been at Emory my whole 20-year career because this is the space that I've been given to study the things that I'm passionate about. We should promote awareness. We ought to use our work to inform policy, and then advocate for resources to continue this work and to enact change. We also need a greater attention to diversity particularly among students and faculty, to conduct this kind of research and do this kind of work more broadly. But there's a lot we can do as individual actors. We can explore what school and work norms and values are anti-racist or racist. How can we create organizational policies, practices, and processes that are racist, that are anti-racist, if we deem that they are indeed racist? We all have a role to play here, and of course, I would be remiss if I didn't argue the importance of voting and really engaging in civic, using your civic responsibility in ways that promote an anti-racist agenda. Now, I'll say I absolutely loved the conversation that Carol Anderson had with Ibram X. Kendi a few weeks ago. Dr. Kendi, in his book, How to Be an Anti-Racist, he encourages us to take an anti-racism lens and ask, how is racism operating here? In his book, he argues that all policies are either racist or anti-racist. There's nothing in between. He argues that there's no such thing as a non-racist or race-neutral policy. Every policy is one or the other. So I'm going to go one step further. Earlier, I argued that racism is comprised of structures, policies, practices, norms, and values. You can extend this question and ask more broadly, how is racism operating in our structures, policies, practices, norms, and values? And those are things that we as individual actors have a responsibility to act on. So there's much work that we need to do as individual actors within our own spheres of influence. And so earlier I argued that APHA's, the American Public Health Association's definition of racism, stated that racism creates conditions that unfairly advantage some and unfairly disadvantage others. we have to start by acknowledging privilege. Now, there's many types of privilege. As a cisgendered, middle-class, able-bodied Christian woman, there is privilege that I enjoy that I don't even see. It's just in the air. There's things happening that just make my life easier, and I don't necessarily know how things would have been different if I didn't have these characteristics. But instead of pretending that this privilege doesn't exist for me, it's my responsibility to use that privilege to right the wrongs that occur in society. So there's a lot of attention lately to the issue of white privilege as a particular form of privilege, but there's been a lot of literature on white privilege for decades in the social sciences literature, so it's not really a new phenomenon. But it's been centralized lately because of its role in sustaining racial disparities in health, which are so profound. So we have to be honest and have honest conversations about the ways in which white privilege supports racial health inequities. We need to educate healthcare professionals and engage in anti-racism education and training opportunities. We should emphasize structures, not the bad apples. In this 2016 paper, Hardiman did a nice job of discussing this issue. And in this paper, they argue, few clinicians come to work on a daily basis saying, I'm going to discriminate against African-American patients today. I'm going to deliver, say, substandard care to Black patients today. Yet physicians operate within larger socio-political economic structures that create clear disparities in health for patients of color. So how do we dismantle those structures instead of focusing on the actions of this specific person? Let's create structures that encourage racial equity, that encourage health equity. We have to examine our own processes and practices and the ways in which they support structural racism. It requires a willingness to make mistakes and to be humble in acknowledging those mistakes. As individual actors, we must learn about, understand, and accept that structural racism is woven into our history, US history. The fact that you all here on this call today demonstrates a willingness to want to understand and learn more and engage on this issue, so thank you for coming. We need to understand the role of racism in driving contemporary health disparities. We need to shift clinical and research focus from race to racism. We've documented that there are racial disparities in just about every major health outcome that exists. So let's move beyond race to understanding racism. In doing so, spurs collective action that goes beyond individual responsibility. And finally, we should shift our viewpoint from a majority group perspective to that of marginalized groups. This is what critical race theory calls centering on the margins. But by kind of reframing the conversation, reframe the discussion. So I'm going to end by coming back to the story. The Pennsylvania amusement park settled a lawsuit that filed by Benjamin Slater. But what is the toll on his health, on his physical, psychological, and emotional health? What about the health of the family members who were with him? What structural factors created the conditions that supported the likelihood that this specific situation would even occur? In conclusion, the United States is a race-conscious society with racism embedded in its social fabric. Naming it and actively working against racism is the work of all of us, myself included, as an African American. The field of public health continues to play an important role in this current movement to address structural racism because of compelling and pervasive racial disparities in health. We may be at a moment in history to change the course of these inequities. And if anybody is like me and watched Hamilton way too many times over the summer, you will be familiar with this phrase that history is watching us. The past and present racial patterning of disease reflects institutionalized racism, present not just in one of our institutions, but in all of them. When we no longer observe these racial disparities in disease occurrence and outcome, our society will have at last vanquished racism. My hope is that the current movement will cause us all to reevaluate our role in structural racism as the first step in eliminating its power. Thank you.
Thank you so much, Kimberly. That was fascinating. You're an amazing presenter, and the material is obviously helps because it's intriguing and interesting. If anyone from the audience has a question, please go ahead and add that to the Q&A little link, which is at the should be at the bottom of your screen. But we have a couple of questions that have come in early. So one actually is a direct response, I think, to your something you were just saying, and that is you suggested that you mentioned anticipated racism, but then I think that was a little bit kind of, you obviously had a limited time, a lot of material. So can you tell us a little bit about that and how that can play out in kind of perpetuating these racial health disparities?
Absolutely. It's a great question. There's actually, it's really interesting on this literature on racism and health because there's increasing evidence that racism doesn't actually have to have occurred to impact the health of African Americans. It's that anticipation, it's that anticipatory response that's damaging to the body. And so you might think of it like this. If you're, out in a store and let's say you're being followed, by a person that works for the store, and you notice that they're following you. Maybe they're following you because they're checking out your handbag and your handbag is amazing. Maybe they're following you because they're distrustful of you because you're African American. If you worry that they're following you because you're Black and they think that you are going to steal, it's that presumption of guilt that I talked about earlier, that can cause physiological changes that repeatedly over time cause poor health outcomes. And so it's not what her intent was, that clerk in the store, it's your expectations. And so in fact, Tanae Lewis does work in this area, does some work around anticipatory racism. And there are increasingly studies that suggest that anticipating racism is associated with physiological changes, regardless of whether the intent of the individual was actually a racist intent.
That's interesting. So I was actually going to ask you more. There's, I've seen several articles recently about, I'm sure there's a better way to describe this, but like the chronic stress cause.
Yeah,
and you obviously mentioned that kind of on behalf of the individual. I was assuming that was one of these micro level factors you were talking about. But then I've also read that it can be like inherited. So it can actually become, so I guess the physiological, excuse all of my health language, which is terrible, but like if it becomes embedded within a person, as you just described, that actually can be something that they can then pass that down. Could you talk a little bit about that and what that means even for our ability to, I guess, it's scary because that means like quick change may be like harder if this is kind of has an inherited component as well.
Yeah, and so you're talking about kind of some epigenetic processes that result in changes in our biology over time.
I definitely wouldn't have called it that.
That change. And so yes, there's a lot of really interesting, exciting work going on in that area. You also spoke to this issue of chronic stress, which can just occur within my lifetime. And so we're not necessarily talking across generations. But chronic stress versus acute stress. And that's a really interesting area of inquiry. And so actually the study I presented earlier, the R21 study that's funded by National Institutes of Health, we're actually studying chronic stress and acute stress. And so chronic stress would look at, whether you are, as an African American, do I perceive that I've experienced racial discrimination at multiple times in my life? And so that's kind of this chronic experience of racial discrimination. And that may clearly be associated with health and create these changes in biological processes. And a lot of this work in my study included looks at inflammation, so change in inflammatory processes. And we know that inflammation is associated with a range of different disease outcomes, right? But this study also looks at acute stress. And so what's kind of interesting about the studies, we're also manipulating experiences of an actual experience of race-related stress. And so participants are randomized to either recall a general stressor or a race-related stressor, and that's what they did when they came back for the clinical portion. And so we monitored their physiological changes, their heart rate, their blood pressure, and then their some inflammatory cytokines while they were before, during, and after their recollection of that experience to look for changes. And so you're spot on when you say, the experience of racism may have an acute change. So, Benjamin Slater in that moment, yeah, I bet his blood pressure went up. There's no doubt. But after repeated events like that over time, what are the long-term impacts on his health? And then your broader question is, how does that impact future generations? A lot of really interesting work is going on in that area.
That's fascinating. So one of our audience members had asked, from their understanding, some of the greatest disparities that we see in healthcare are in maternal health, which obviously also has kind of an intergenerational component to the extent that it's affecting, the child. Can you talk a little bit about that and how that relates to kind of some of the other issues you're talking about here?
Yeah, that's a great comment. I mean, it's always been interesting to me that particular area. So I'll tell you that when it comes to the literature on racism and health, a lot of this work has stemmed from maternal and child health, just like the question, hit on, and cardiovascular outcomes. And the work on CVD, cardiovascular outcomes, is because, racism is a form of stress, and there's a long literature linking stress to cardiovascular outcomes. But the maternal child health is particularly interesting. And I'll say that and that's why I even had a slide that talked about structural racism and infant mortality, because I feel like that's an area where they're really leading field in understanding the effects of structural racism on health. But that's an area where the literature is rather large, and it's really growing beyond these individual experiences of racism to larger structural factors. I'll say I have a thesis student. I don't know if she's listening, but her thesis is on this topic of experiences of racism and preterm birth. What's really interesting is we have some leading scholars in this area right here at Emory. So Michael Kramer is one of the leading scholars in the field on the role of racism and maternal and child health outcomes. He's in the Department of Epidemiology. Carol Hogue retired just a year or two ago, but leading scholar in this area. And then there's others. One of my former professors at Spelman, Fleta Mask Jackson, who's done amazing work in this area. But I would say the scholars in this area they're far ahead those of us doing work in transplant. I feel like renal disease, we're light years behind where the MCH literature is in understanding the effects of racism on health. And it might be because so much more is known about the biological processes of transmission from mom to child. And so they just kind of got ahead in terms of understanding how mom's experiences of racism impact both mom and baby. So it's a really interesting area.
Yeah, I mean, I read something, I can't remember the exact statistics, but that, when you look over the past 100 years and how white maternal morbidity and infant morbidity and all those rates have improved so much, there's been such a smaller improvement in those same numbers for African American and Native American groups.
That's exactly right. And I mean, there's a study that Carol was involved in, and Dr. Jackson, a range of other folks, that's old. I mean, the study is probably 15, maybe at least 15 years old, that documented that education does not protect Black women from poor birth outcomes. And so in most cases, education is a protective effect. And so the more education you have, the more health, the better health you have. But when it comes to maternal and child health, when it specifically comes to birth outcomes, Black college-age women have worse birth outcomes than white high school educated women.
Yeah.
And now that's profound. I mean, that's really profound. And so that's the kind of work that really harkens back to the role of racism. If education is not protective, what is it? It's racism. And so, yeah, that work was conducted, in the earlier parts of my career when we're just kind of getting to talk about these issues in the transplant literature now.
Yeah. Okay, I've got various things from people here. So I guess on a related point to that, one of our audience members has asked, what is the specific role that structural racism could play on maternal mortality or morbidity or whatever it is we're talking about? And so you've gone through all of these different factors.
Oh gosh, there's a lot. There's lots. So Michael's work focused, I'll just start there, on segregation. And so residential segregation. And so it's very clear, or there's increasing evidence, I should say, that residential racial segregation has clear and profound effects on the health of populations. And so you say, well, what's the specific effects? So the laws that condone and support residential segregation may have been dismantled, but their effects continue until today, right? So it's the de jure versus the de facto. And, racial segregation is, very clear today. I showed you a picture of Pine Bluff, Arkansas. So women residing in certain neighborhoods have less access. I mean, there's a range of different mechanisms. The question is really about mechanisms. So you could hypothesize a range of different mechanisms. I'm just going to throw out a few. But there's lots. So there's air quality. Certain neighborhoods are closer to certain, environmental health is not my area, but I know that poor Black and brown communities tend to be in areas that have greater environmental waste exposures. And so exposure to environmental waste could certainly impact the birth and the health of a baby. And so there's neighborhood characteristics, including air quality, including access to healthy food, which impacts the mother's weight, which has very clear implications for outcomes. And then there's stress. I mean, there's lots of evidence that there's, neighborhood related stress and exposure to violence that women experience before and during pregnancy that impacts the birth of the child. And so those are just like the top few that come to mind, but we could probably go on and on and on about how something like residential segregation filters, gets under the skin for mom and baby.
Great, excellent. Okay, so I've got just some amazing questions here. I'm going to jump around a little bit. So Dorothy Roberts at Penn spoke at the law school, I guess it was about a year and a half ago now. And she had talked a bit about race-based medicine and that in some areas it could be an impediment to good medicine. So for example, to the extent that there were different acceptable levels of things like sugar in the blood or acceptable lung capacity, that medical doctors were they had this idea of there being acceptable differences between the races. But now as we've learned more and more about the genetic truth about race, do you think that kind of race-based medicine is an impediment to good medicine?
Well, so medicine is not my field. Yeah. And so I can't really answer that question intelligibly with great certainty. I will say it's something that we're all grappling with. I'll tell you that in the world of transplant, there's some discussions right now about the use of race in estimated GFR, which is a measure of kidney functioning. And should race be factored in, and to what extent would that advantage or disadvantage Black patients? And so I'm kind of just monitoring this conversation, this debate from the outside, because again, I'm not a medical doctor. But I will say that, at the end of the day, it's a question that we need to grapple with. And so the question is, does incorporating race into the formula, does it, going back to Kendi's argument, does it form an anti-racist or a racist agenda?
Right.
And so we've got to look at the data and understand and acknowledge that it's in one of the two camps, and then be intentional about what we're going to do. I think having that conversation and looking at the data from an anti-racist lens is a good way to approach it. Yeah,
no, that's helpful. Speaking about kind of mentioning, I don't know, the perhaps even the different, there's sometimes could be a disconnect. One of our audience members has said there sometimes seems to be kind of a disconnect between the conversations that people in public health are having about a lot of these things and the way that medicine's actually being practiced on the ground. And as she's a medical doctor herself and has sometimes struggled trying to educate her colleagues about a lot of these things, because there are a lot of these larger discussions happening. So do you have any advice about that?
No, I just think that comment is spot on. I mean, I don't have really great suggestions. I mean, I will say that I love when clinicians have a public health perspective. I think that in general, I'm not talking about racism now, but we need greater integration and synthesis between medicine and public health. And so when physicians have training in public health, and when people get an MPH first and decide to go get an MD, like those are the people that can think both at the individual and the macro level beautifully, which is actually exactly where this question is coming from, which is why it's such a great question. So I would say medicine and public health, we want to integrate them more seamlessly in general. But I think at the end of the day, it kind of comes back to just, we have to rethink some of our processes. And so, medicine by definition is very focused on individual people. Public health, we're very focused on the health of populations. We actually need both. This is not an either or thing. But because of that, I think that perhaps there's a tendency in medicine to think about racism from an individual perspective, and as public health, we're trying to push conversations about racism from a structural perspective. So we've got to just work together and thinking. This kind of goes back to my argument earlier about structures versus bad apples. This is not about bad apples, individual people who are just bad actors. Let's work together to think about the structures that support the persistence of racial inequities in health. And there's been a lot of really great collaborations between medicine and public health, so I don't want to overstate this issue, but we need more.
Yeah, no, it sounds like that. So interesting segue. So you were talking about kind of the structural versus bad apples. I guess a different way of thinking about this. So I've also read quite a bit about just the kind of striking lack of diversity there is in the healthcare profession. And there's a lot of people say that obviously that could improve a lot of things, right? So you might have African-American patients who feel like they can be more open with their doctors, or maybe they're listened to more, all of that. But then there's also the structural racism, which I'm not as convinced like how easy it will be for even more diversity to change that in some way. So how do you kind of balance those, I mean, and obviously diversity I think could help a lot, but I don't know, how do you think about those issues?
No, it's a great comment. I mean, I have lots of thoughts, so many. I was trying to scribble a few down on paper, but so one, we need diversity, yes, but we need inclusion and we need equity. And so diversity isn't enough. And so we have to be very leery of efforts that are just about diversity, because once you diversify, the healthcare professionals the question becomes, is this an inclusive environment where people feel valued? And we've got to pay attention to both. Are decisions made in an equitable way? So I worry when too much emphasis is placed on diversity without attention to equity and inclusion. So that's my first worry. But there's evidence that suggests that Black patients fare well when they're seen by Black doctors as compared to white doctors. There's a study that came out on this just a couple of weeks ago. I saw something. But to me, it's not a question of either or, it's both and, right? Mm-hmm. So yes, we need a more diverse workforce. And I'm not talking just clinicians, I'm talking about in the academy as well. I'm talking about in the faculty. I mean, I think it's unfortunate that I'm the only full professor African-American in the School of Public Health. That's something we need to work on. And so I feel like what we need to be thinking about is diversifying the academy and the healthcare system and all these different areas. But we also need, so this is the both and, we also need to create these structures that encourage awareness and education of those who are non-Black. Right. So that's why I say both and. And so, we need to engage in efforts around anti-racism trainings that are evidence-based and that have demonstrated outcomes. Because this is what we need. This is what is probably, this is going to be most helpful to dismantle some of the structures. But so we need to address the structures that include creating opportunities to educate and enhance the work of those who are working in the fields of medicine and public health.
Yes, great. Okay, so this is an area close to your heart, given all of your research in this. Can you talk about why the transplant route is so leaky for patients of color? Is it the doctors are not providing enough information or encouragement? Is it the requirements on patients to have to go to multiple locations if they're having to miss work or take public transportation to do so? Is it a health insurance issue? And I guess it could be all of the above plus more, but where do you guys think a lot of these problems exist?
No, it's just a great question. So it's all of that, but those are the proximal factors. So I actually took out a slide in the interest of time where I talked about racism as a fundamental cause of health inequities. And I talked about how, if I had presented the slide, I would have talked about how, when we think about proximal factors, you could say, well, obesity is a risk factor for diabetes. But racism is a fundamental cause of health inequities. That means it impacts the risk factors that cause the disease. So in the case of obesity, you would say, well, what are the factors that contribute to the obesity epidemic in this country? Maybe it's our social and cultural values around portion size, or maybe it's has to do with the foods that people are incentivized to produce versus disincentivized to produce. So we could talk about a range of things. Same thing, I would say racism is a fundamental cause. And so it's not just that Black patients are referred at lower rates than white patients. That would be a proximal factor. It's not just that African Americans are less likely to have private health insurance than white patients, and access to private health insurance is a leading determinant of access to transplant. It's not just that. It's what are the kind of those downstream factors that contributed to those situations. So I would say at the foundation are clear and profound inequities in income, education, employment, and health insurance that are longstanding, that are intergenerational. I would say those factors, you know, again, with race, they stem from racism as a fundamental cause of health inequities. They're the factors that lead into the factors that we see: the lower referral rates, the lower evaluation initiation, the lower likelihood of evaluation completion, the less likelihood of preemptive transplant. Those observations are a function of these longstanding historical trends.
Okay, so to bring this into the kind of current discussion about COVID, and that was I hadn't seen that slide you put up about the very like clear, kind of racial disparities, even though we read so many articles about that, so that was helpful. I've also read a little bit about the, I guess, public health experts starting to become concerned about acceptance of a vaccine whenever there is an actual proper vaccine, and that this could be, it would not be surprising if people who had good reason to distrust the government in certain ways could also be, distrustful of that. And so is that something that, it doesn't sound like it's that closely related to your work, but have you thought any about that?
Very much
about that?
It's very much closely related. I mean, from my standpoint, that's the elephant in the room when we're talking about vaccines. That's huge. I mean, I'll just share with you that 20 years ago, I started my career my first National Institutes of Health RL1 study was in the area of organ and tissue donation. And I was really interested, and that's how I kind of got in the transplant world. I was really interested in organ and tissue donation, disparities in it, because African Americans donate at lower rates than whites because of real and persistent and well-deserved distrust of the healthcare establishment, right? It's well-deserved. And so I was really intrigued by this idea of developing interventions to encourage a health behavior in the context of these well-deserved distrust. And how do you do that? How do you have to acknowledge the distrust and then develop interventions that still say, but African Americans are overrepresented among those who need organs. So I've always been intrigued. And so this issue of distrust of healthcare and medical racism more broadly is something that I've always been interested in. And so of course, this vaccine, as it comes to market, there's just a lot of questions around distrust that this has already raised and will continue to raise. And it's because it's not just historical injustices, there are current injustices as well. So it's not that was then, this is now, this is still now, right? And so I think, I have people ask all the time, what are your thoughts on vaccines? And in general, I think they're good. I got my flu vaccine, and so I encourage people to do that. I think that on the COVID vaccine, we need to follow the science, and we need to look at the trials and make, the evidence and the trials, the evidence that's stemming from the clinical trials, and make decisions that are best for us, individuals, outside of the scope of the political maneuvering that's happening around vaccine trials. I think we need to continue to be skeptical,
right?
And watch and see what happens.
Yeah, but you're right. I mean, to the extent there was already distrust about all this in the first place, all of this political maneuvering is only making all of that worse, right? It's just exacerbating, this distrust.
Some people are like, I'll just sit back and wait. I'm going to hang out over here and kind of see what happens.
Totally. Going back a bit, have there been people who have examined the health effects for families or individuals who have moved from a segregated area to a less segregated area? Like,
Yeah.
are there relatively immediate or shorter term benefits in their health outcomes?
So there's this big study called Moving to Opportunity. And so I encourage people who have interest in these kind of structural interventions to really examine the findings of these studies. But Moving to Opportunity was a large study that it did exactly what you talked about. It looked at the effects of moving people from primarily low income segregated neighborhoods to more diverse middle income neighborhoods. And the findings, the study has some methodological flaws. Anytime you want to understand make causal assertions, you're looking for randomized design. Randomization was not possible for something like that. And so, there's some, questions about threats to internal validity that are, legitimate.
Right.
That being said, there's general evidence that moving to middle-class neighborhoods did improve the health on a range of different indicators for those who were involved in the study. Hannah Cooper has done this work, and she's right here at Rollins, but she has studied substance use and HIV risk behaviors for people who move to different neighborhoods, from more segregated neighborhoods to less segregated neighborhoods, and has had some interesting findings. So I encourage people to look at her work as well. But yeah, those are exactly the kinds of structural interventions that we're seeing people conduct, but it's a challenge. It's really complicated because moving to different neighborhoods also can disrupt social connections. And so there could be unintended consequences of that move if positive social interactions are disrupted. So it's not as simple as just kind of moving to a neighborhood that's of higher income. You've got to figure out how to do that in a way that doesn't disrupt the benefits, the positive aspects of being near the people closer to the people you care about.
Right. So I think we only have a few seconds left. This is going to cut off at 1:15, but thank you so much. This was so enlightening. And I think that, I'm sure for all of the community out there, it was great, but I think even for our law students to see how so many things relate. Environmental law relates to health disparities and obviously voter issues and all of these things. I think you really did a great job of showing us the big picture. So thank you so much for joining.
You're welcome. Have a great day.
Thank you.
Bye.